We've heard so much about novel interventions for the myeloma population. Pomalidomide, ixazomib, isatuximab, BiTEs, chimeric antigen receptor, T cells. How will that fit? How will that affect the amyloidosis population?
Well, I think they're very important advances. I'll talk a little bit about those agents and another agent called venetoclax tomorrow in my presentation. But I think there is going to be a role for many of those agents. For example, Dr. Sanchorawala has done trials with a drug called lenalidomide and also done trials with pomalidomide, which were difficult trials to do because they were being used in patients who had advanced organ damage and who were heavily pretreated. In the modern era, with the availability of daratumumab, what we can do is treat patients for 2 cycles with an immunomodulatory agent, a monoclonal antibody, and patients who may not have responded to other things have a good chance of responding to those combinations. We'll present some data tomorrow on the target of the current advanced immunotherapies, B-cell maturation antigen, BCMA. And what we show is that BCMA is certainly present on plasma cells in light chain amyloidosis, and the soluble protein that circulates in the blood that complicates to some degree the dosing of these immunotherapeutic agents is significantly lower in AL amyloidosis, meaning that perhaps with lower doses, with the smaller family of pathologic cells in the bone marrow, the agents may have more efficacy. I'm actively courting the major drug companies that have these agents in clinical development, and there's a reluctance to commit to light chain amyloidosis, but you just have to keep knocking on the door.
Professor Sanchorawala, you were key in the development of our understanding of novel agents in the management of amyloidosis. Where are we going forward with new agents for amyloidosis?
So as Professor Comenzo mentioned, not all patients are eligible or are benefiting from the current novel agents that we have. So the newer novel agents, quote unquote, are definitely going to play a big role in this treatment paradigm of AL amyloidosis. The immunomodulatory agents, they are effective in relapse setting for AL amyloidosis. However, they have certain disease-specific side effects with regards to paradoxical increase in cardiac biomarkers while patients are receiving immunomodulatory agents, making the cardiac response assessment difficult, and also renal dysfunction that was shown in several of the clinical trials to occur in almost 50 to 60% of the patients while receiving immunomodulatory agents. So I think newer agents with better toxicity profile, better tolerability for patients with multi-organ dysfunction are going to be the next few clinical trials. We currently also have the trial that just completed accrual of Southwest Oncology Group 1702 of a phase 2 trial of isatuximab in relapsed AL amyloidosis. 40 patients have been enrolled in all across the country, and we await the results, but the preliminary results are looking quite promising.
Over the past 2 years, 3 new agents have been developed for the management of hereditary amyloidosis of the TTR type. 2 are one stabilizer and 2 inhibitors of the production of the TTR protein. I'd like you both, actually, starting with Professor Sanchorawala, comment on the utilization and what will happen to liver transplantation, the prior standard for this disorder.
So it is absolutely an honor and pleasure to be in this space to really see the development of approval of these 3 new agents in the past year for this very rare and hereditary amyloidosis that there was no treatment for all, many decades. Liver transplantation was the standard of care for certain types of mutations associated with transthyretin hereditary amyloidosis. However, with the advent of gene silencers, I think liver transplantation may not be the right treatment. However, in certain types of mutations, particularly V30M mutation, which is common in Portugal, Sweden, and Japan, that may still have a little bit of a role. Now, again, I think it all depends on younger patient population. It depends on the kindred of a particular mutation family. But I think that the gene silencers have probably taken over the liver transplantation for hereditary type of amyloidosis.
Just a minute, Professor Comenzo. How do these silencers and stabilizers work?
So the transthyretin molecule has 4 parts, like a 4-leaf clover. The stabilizer prevents the 4-leaf clover from coming apart because it's the individual pieces that cause amyloid. The silencers are molecules that interfere with the manufacture of the protein inside of the cell. RNA needs to be translated into protein, and basically the silencers silence the RNA.
Thank you. And in terms of tafamidis, could you clarify its mode of action?
Tafamidis is a stabilizer. It enables the 4-leaf clover to remain intact, preventing the availability of the monomer that causes amyloid. It's an oral agent. Patients take pills every day at certain doses, and all 3 of these agents have shown benefit in a significant fraction of patients after about 10 months of treatment.
Professor Sanchorawala, could you clarify the indications for silencers and stabilizers in the amyloid population?
So the stabilizer that is approved is tafamidis, and that is approved for patients with transthyretin cardiomyopathy, which is wild type or acquired. It is also approved for patients with New York Heart Association class 1 and 2. So patients, when they are very advanced with wild-type cardiomyopathy, this drug may not work. As Professor Comenzo said, it does take about 18 months or 10 months to really have an effect. It decreases cardiovascular hospitalizations. The silencers, the transthyretin silencers that are approved are patisiran and inotersen, and both of them are approved for familial amyloid polyneuropathy stage 1 and 2.
So the silencers are not approved for the heart, the stabilizers are not approved for the nerve.
That is correct.
Thank you. Light chain deposition disease appears to be a form of amyloid variant. Could you discuss a little bit about the pathophysiology and how you treat it?
So first of all, light chains aren't light chains because they light up. Light chains are light chains because they're the smaller part of an antibody molecule. Normal plasma cells make an excess of light chains, and when plasma cells become malignant, a significant fraction of the time, they make significant amounts of light chains. Some of these light chains go on to cause amyloid. Some of them don't cause organ damage, but circulate. And at times, some of them can aggregate in the body's organs as lumps of light chains, classically in the kidneys, but also in other organs as well. It has to do with the physical-chemical character of the light chains and their ability to get into certain anatomic areas, particularly within the kidney, that interfere with normal organ function, causing the kidneys, which are a great sieve to help us hold on to good proteins and eliminate waste. The damage that's done to these little filtration units results in leakage of protein into the urine, leakage of good protein, so the liver has to work overtime to make more good protein. Eventually, the patients are quite ill as the result of the fatigue associated with liver hyperactivity and the protein losses. In addition, there are other parts of the kidneys that are extremely important for handling waste, particularly the tubules and the areas around the tubules. And if deposits occur in those areas, particularly in the first part of the tubules, those patients can go into kidney failure pretty quickly without a lot of proteinuria. So we know that light chain deposition disease is morbid. We know that it isn't always associated with multiple myeloma. And as our nephrology colleagues become more sensitive to the issue, we are seeing more and more patients who have what's called monoclonal gammopathy of renal significance, many of whom have light chain deposition disease.
And I think one other point to clarify is that in amyloidosis, you have to demonstrate amyloid fibrils or amyloid deposits, which are Congo red positive. They stain with Congo red staining and show up as apple green birefringence when examined under polarized light microscopy. On electron microscopy, the amyloid fibrils are 8 to 10 nanometer in diameter, whereas in light chain deposition disease, the Congo red stain is negative because there is no fibril formation, and it is deposited as floccules, globules, lumps of light chains, usually in the glomerulus and the basement membrane of the glomerulus. So that is the pathophysiologic or histopathological difference of AL amyloidosis versus light chain deposition disease.
How do you treat it?
So it is again a plasma cell dyscrasia. So the treatment is usually either a proteasome inhibitor-based therapy like with bortezomib, and also stem cell transplantation. So there are published reports on bortezomib and dexamethasone leading to long-term remissions of light chain deposition disease, as well as reports of stem cell transplantation with long-term data on stem cell transplantation for response of light chain deposition disease.
Professor Comenzo, will daratumumab fit in the profile for this rare disorder?
Absolutely, yes. The plasma cells that cause multiple myeloma, AL amyloidosis, light chain deposition disease, all express that target antigen, CD38, that daratumumab attacks. One of the useful aspects of AL amyloid and light chain deposition disease is that those patients are likely more immunologically intact than perhaps some multiple myeloma patients. And therefore, daratumumab may have a major role to play in both AL and light chain deposition disease, eliminating the factor causing the disease.
I want to thank you both for your participation. I found it highly instructive and valuable for our audience.
Thank you, Dr.
Thank you.
Gertz.
Thank you,
It's been
Dr.
a pleasure.